I made a video about the myth that 150 is this magic number where any heart rate below 150 is sinus tachycardia and any heart rate above 150 is supraventricular tachycardia. And I indicated that the biggest differentiator between sinus tach and SVT is your patient's history, and that generally speaking, it's the most important differentiator, more important even than your ECG. I found a recent case study that really drives this point home, so let's go over it. This case study is of a 27-year-old female with a week-long history of shortness of breath. During that time, she was seen at an urgent care twice, but she received no diagnosis or treatment. She suffers an acute exacerbation of her condition, so she calls 911, and EMS notes that upon their arrival, she was in respiratory distress with labored breathing, she was pale, she was diaphoretic, and she was hypoxemic with a room air saturation of 79% that only improved to 90% on 15 liters non-rebreather. Her blood pressure was 125/99 and her heart rate was 165. Now, I don't need to see the ECG, and I'm sure you don't need to either, to have a specific diagnosis very high in your differential, but let's look at the ECG anyway. So here's the ECG. We have a heart rate of 161. We have a monitor interpretation of supraventricular tachycardia, which the crew probably became hyper-focused on, but there's a couple of findings on here that kind of lead us away from SVT. For starters, there are very visible P waves. Those are often, not always, but often not visible in the presence of SVT, and we have an indication of right heart strain. We have a prominent S wave in lead 1, a prominent Q wave in lead 3, and I'm not sure what's going on with those T waves in lead 3, but this may be an S1Q3 T3 pattern, which, when coupled with the patient's signs and symptoms, paint a very large picture of that specific diagnosis that we're talking about in your differential. But the crew proceeds to administer 6 milligrams of adenosine. The patient goes into PEA arrest, is never resuscitated, and upon the autopsy is found to have a pulmonary embolism. There's a saying in medicine: if you listen to the patient, they will tell you what is wrong. Your history taking is one of the most important tools in your toolbox, and when you couple that with the patient's signs and symptoms, you'll often get about 75% of the way towards a strong differential without requiring any other information. Remember that sinus tachycardia is the most consistent ECG finding when it comes to pulmonary embolism, and in fact, a 27-year-old is capable of a sinus tach of around 190. Be very skeptical of monitor interpretations. Whenever you see a monitor interpretation like this, ask yourself, does this match the patient's story?